So this lecture will help you fill in your notes looking at heart physiology or how the heart functions. We are going to be looking at blood pressure first and then going into, again, how are we moving everything around. Starting off with blood pressure, you've probably heard of it. You may have gotten yours taken. You may have heard people having issues with theirs. The idea behind blood pressure is this is the pressure or the force exerted by blood on the walls of blood vessels when the ventricles contract. So in looking here, for instance, if the heart is pumping that blood, it's sort of like being water in a hose. It's going to push on the walls of that hose. A couple of things blood pressure will change depending on. One of the first things is just how much blood you got, total blood volume. We can see a correlation between amount of blood and blood pressure in the sense that if you have more blood for whatever reason, you have higher blood pressure. And then the opposite is also true. Less blood, you have less blood pressure. The next thing is how much blood your ventricles pump. So if they're pumping more, for instance, if you are exercising or under a lot of stress, your blood pressure may go up. But if you're relaxing and your blood pressure, your ventricles are pumping less, then your blood pressure goes down. The last one is constriction in our arterioles, whether your arterioles are constricted. If they are constricted, we have a lot of pressure on the blood, so we have higher blood pressure. But if they're dilated, they're more open, there is less of the blood pushing up against the walls, so your blood pressure goes down. Now, your body can compensate for this. If you lose a lot of blood, for instance, and your blood pressure drops, your body sometimes tries to raise it by having your heart rate go up, your blood ventricles pumping more blood. So just as a heads up, we can also change this as well in hospitals. If your heart rate is too low or your blood volume goes down, we have to consider blood pressure in our treatment. Now, you guys have probably, again, taken blood pressure. We do want to measure blood pressure pushing up against the walls of arteries, but we want to be consistent because even if we're looking at this, it's going to change whether we're in the aorta or something further away. So we typically measure blood pressure at the brachial artery. It's in the arm, so we have the upper arm brachial. A couple of reasons, it's fairly consistent among people. It doesn't change a whole lot. It's big enough to be felt, so we need something we can measure, and it's easy to get to more so than, for example, your femoral artery in your thigh. Now, if you ever got blood pressure, we know that we have these two numbers, systolic and diastolic. The top number, systolic, that's when your ventricles contract. It's your peak pressure. So this is going to be right after your ventricles push out a ton of blood. It's standing by the fire hose. You just got a ton of pressure on you. That is the highest your pressure is currently going. Whereas diastolic, well, that's when your heart relaxes, your ventricles relax. It's no longer pushing blood. There's still blood in there, so that number is not zero, but is the lowest pressure at which your heart is operating. So we basically, when we get this 120/80, we're saying that your blood pressure is a range there, 120s being your highest number and 80 being your lowest number, but you kind of change in between. In class, we're probably going to practice taking blood pressure. If you've ever had this done, you know that one of the things is you want to be listening. There's some kind of stethoscope either attached to a machine or a person. We have a cuff that can be filled with air. We are going to be using cuffs with bulbs. So there's a valve as you squeeze that, and the valve is nice and open. It's going to push air into the cuff and inflate that cuff. As that cuff gets larger, if you've ever had your blood pressure taken, you know it squeezes your arm so tight that circulation is actually temporarily cut off. One of the reasons we do that, we're going to increase our blood pressure cuff up to 200. What happens is your blood pressure yourself is like 120. That's not enough pressure to push past the pressure that the cuff is putting on the arm. What we do then is we slowly release the pressure. And at a certain point, our own blood pressure that is pushing up against the walls of the artery matches the blood pressure cuff. That is your systole. We know it is your systole because at that point, blood is now forcing its way through the blood vessel and we can hear a pulse. We're going to continue after that point to relax, relax, relax until we can no longer hear any numbers. What that means is the blood pressure cuff is now so loose that even the lowest pressure isn't pushing on it anymore. Now, you can have blood pressure that's too high. We call that hypertension. It used to be, and depending on where you are, still is defined as high blood pressure above 140/90. We have recently been recommended to lower that number because we are still seeing some issues at 130/80. So what we're doing is we're just changing treatment options. We're saying that we really want to start pushing treatment at 130/80. A couple of things with hypertension, besides the fact that it's just high blood pressure, is it usually is caused by things that lead to narrowed arteries. Remember that when you constrict your arterioles, you are going to have higher blood pressure. If you artificially narrow your arteries, it's kind of like artificially constricting them, which will increase your blood pressure. Genetics can do this. Some people just have naturally more narrow arteries or arteries that become less flexible with age. But a couple of things that can be worked against and treated. First one, sedentary lifestyles. You're not exercising, so your blood vessels aren't super flexible, and that kind of leads to stuff being clogged on the inside of your arteries, along with an unhealthy diet. Stress is going to increase heart rate over a long period of time, so it can artificially lead to higher blood pressure over a long period of time. An unhealthy diet will start to put, as I mentioned, things into the blood that stick to the walls. It can build up and be a cause for more serious conditions. But that stuff sticking to the walls, that plaque, leads to, again, artificially narrowed arteries. And smoking cigarettes leads to arteries being more inflexible and thus acting as though they are narrowed because they cannot widen. Risk factors, basically, what can hypertension lead to? One thing is with high blood pressure, your heart works harder. That can lead to actually, instead of with the rest of your muscle beefing up, your heart can start to fail, which means that it is not pumping as much. It can get tired and worn out. Your kidneys filter your blood, and with high blood pressure, we are forcing them to work harder, and that high blood pressure can actually start destroying tiny, tiny little functions within the kidneys. That can lead to kidney failure over time, a loss of function in the kidneys. And we have things called heart attacks and strokes. Both of those are caused by a clot blocking blood flow through whatever artery we are looking at. Now, with heart attacks and strokes, the risk of those goes up with narrowed arteries from an unhealthy diet. So if somebody has hypertension, they are more likely to get heart failures, kidney failures, and heart attacks and strokes. So we always want to whenever we see hypertension, we want to modify lifestyles and introduce medications to lower blood pressure so we don't get those risk factors. So systolic, contraction, diastolic, relaxation. We're going to have the highest pressure here and the lowest pressure here. So with cardiac muscle, we already know that cardiac muscle is special. It's a specialized type of muscle with specific features. Still contracts through the sliding filament model. So we still have those striations, those stripes, easier to see on some parts of this slide than others. We still have actin and myosin. Some things that are different. Cardiac muscle has more mitochondria because unlike your skeletal muscle, cardiac muscle don't quit. It never takes a break. And cells have to communicate with each other. When we learn about how the heart beats, these cells kind of beat in a wave. Like if you ever went to a baseball game, you see people doing the wave. One cell going off will trigger the next one. They do this through intercalated discs. Essentially, they have openings between cells that help them communicate. We call these openings gap junction, like open doors between these two cells. The next thing to look at is the cardiac cycle. Your heart is, always alternating between relaxation, diastole, and contraction, systole. So we have to contract and then relax and start the whole cycle over again. It's a little more specific. So first up, the first relaxation that happens is the atria. As the atria relax, blood is going to flow through them, and they're also going to flow through our valves, our tricuspid and mitral valves, into our ventricles. Then the atria are going to contract, and that's going to push any blood that's in the atria into our ventricles. Afterwards, our ventricles contract. They push that blood out of the heart through our valves into like our aorta and our pulmonary arteries, so the aortic and pulmonary valves. And then once they have contracted, they will then relax. Once they relax, these valves, the aortic and pulmonary valves, close to prevent backflow from the blood vessels back into the heart. And this all restarts with the atria relaxing. Okay, so we can kind of see this: contract, contract, relax, contract, contract, relax, refill, contract, contract, relax, refill. You can find these images, by the way, online by just searching up cardiac cycle and going through Google Image. So you can kind of watch this: contract, contract, relax, refill. All right. And another thing to mention, as we already kind of mentioned, these are contracting in a coordinated fashion. We don't want them to contract kind of doing their own thing. All the ventricle cells have to contract at once. All the atrial cells have to contract at once. And it's kind of like a ringing motion going from bottom to top. Now, weirdly enough, you can take the heart out of the body and it will still contract because it'll still go through the cycle, which you can pause and look at. But because it has a conduction system, all the electrical signals to conduct the heart come from within. So the definition of a cardiac conduction system is that we have nodes firing action potentials around 70 times per minute to contract the heart. To break that down, these nodes are these little buttons, and when they fire off, those action potentials go along and trigger these cells to beat, to contract. We have two. We have one on top and one at bottom. Let's go ahead then. We are going to be looking at these nodes. A node in general is a central and connecting point, and these nodes are going to set the pace of heartbeats. We sometimes call them our cardiac pacemakers. One of the things you have to talk about is which nodes do we have and where are they located? So starting off, we have our SA node. SA stands for sinoatrial, meaning the atrium wall, for sino, like sinus. This is located specifically in the right atrium's wall, and again, it'll fire off. One of the things it'll trigger is the next node, the AV node. The AV is located between the atrium and the ventricle on the right side of the heart. So AV, between the atrium and the ventricle. Now, what they specifically do, the SA node will trigger the contraction of the atria, and the AV node will then kind of act as a bridge between the SA node and the ventricles and cause them to contract the ventricles. So that SA node signal goes to the AV node, which is the electrical bridge, sending the signal to contract the ventricles. Feel free to pause here to finish getting down your notes on the SA and AV node. Again, you need where they are, what are their names, and what each one does. So in looking at this picture, right, we have our SA node right up here. When it contracts, it's going to talk with both of the atria to contract, and then it sends that signal down to the AV node, which will trigger off a signal all the way through here. We can see it here. So now we have the same picture of the cardiac cycle, but with our nodes highlighted. Right, once this fires off, we get contract. This is going to fire off down there and do another contraction, and then we relax. This happens about, for most people, 70 times per minute. So we're going to continue on next time to look at tests. One of the things we're visiting now is essentially looking at our circulatory system. It's connected to every other system in the body. So even though, nervous and integumentary aren't included, they're down here. Rapid transport to and from all living cells. This includes endocrine. This is also looking at how the digestive system takes in food and water and gives your circulatory system the nutrients, water, and salts it needs to move around. Your respiratory system is always bringing in oxygen and bringing out carbon dioxide and exchanging that with your blood. Your urinary system takes out waste products, excess water, salts, and waste out of your blood and puts back in anything we need, like water and solutes. So this right here is returning things to the blood and filtering the blood. And we're going to see this again, but your circulatory system, hands down, is one of your top most important organs. So you should know essentially what is blood pressure, how it functions, what determines blood pressure, right? Blood volume, for instance. You should know how cardiac muscle functions. Very, very simply talking about, what makes it different, what makes it the same. And then the general steps to a heartbeat. Okay, you don't need to know a ton of specifics, but we did need to talk about the cardiac cycle. More specifically, you should know about those nodes, where they are, what action they signal. So we should know about SA and AV node. where they're located, and how the SA node triggers atrial contractions and AV node triggers ventricular contractions.